Mohammed, Professor of Cardiothoracic Anesthesia and Surgical Intensive Care, Mansoura University. I'm honored to present Dr. Mohammed. Dr. Mohammed will talk about an interesting topic for all anesthetists, especially pediatric anesthetists, pediatric difficult airway. تفضل دكتور محمد.
Thanks so much. Thank you, Dr. Saad, for your great efforts to implement this initiative. And thank you, Professor Manal, for introducing me. During the following 40 minutes, I'll talk about the pediatric difficult airway management, the role of video laryngoscope. First of all, I declare I received the free airway device samples from AMBO US and AirTrack UK in 2014 and 2015 for use in published studies, and I have no direct financial or other interest in AMBO, AirTrack, or any other industry in the context of this lecture or my studies. I'll go to introduce the word and new era of video laryngoscopes in pediatrics, and emphasizing on applications, advantages, disadvantages, and types, and then try to address an answer for the alerting question, which is best to reach for a conclusion. First of all, the concept of video laryngoscopes was born secondary to the advances in telescopy. Telescopy started from rifles and military, used by military, as you can see here on the left side, and also by our colleagues in endoscopy suites and as well as in laparoscopy, endoscopy. They are introduced, they're going to using these advances in telescopy for laparoscopy, for thoracoscopy, and so on. The same concept came for laryngoscopes. You know, we are using direct laryngoscopes, which need alignment of different axes. I'll show you to get the best view. However, there are two main types of video laryngoscopes. Either fiber optic laryngoscope with a cable, as you can see here, is connecting the image from the tip of the blade to a remote screen. Or another one is a digital laryngoscope with the microchips in transmitting the image to also to the remote screen attached to the handle of the scope. We have three poles. You need to address them. Can Dr. Saad start with the first pole, please? Dr. Saad? Okay, here I have a question for all of you. Have you ever used a video laryngoscope in your clinical practice? Regularly, occasionally, rarely, never, not accessible to you? Can you click one of them, please?
Yeah, we finished now.
Okay, can we take a look for the results?
Share now here. Do you see the result now?
Yes. As you can see here, about half of respondents are clicking on regularly using or occasionally using. At least we have about 70% or more are using video laryngoscopes. Interestingly, we have 9% they don't have accessible video laryngoscopes. We'll go for the next one. We have a next poll. Have you ever used the video laryngoscope for a pediatric patient regularly, occasionally, rarely, never, or not accessible? Dr. Saad, please.
Okay, just 1 second, please. I try to share the second one. No, not this one. Okay, 1 second, please. What is the second? I need to get that.
Okay.
For some reason, I am not able to get it. This is that's the first poll. I need to
Okay.
go through the second poll.
Sorry.
No, I couldn't get the second poll done.
No problem. It's okay.
Okay, thank you. So they
Why
can share
I'm
the
asking
result on the chat. They can see that in the chat. They
is the
can do
first
that in the
one.
chat.
Is the first one. Is the first poll.
This is the first poll, Dr. Saad.
I understand. But they can do this one on the chat. They can do the second one on the chat because I couldn't get the
It
second
would be
one.
difficult to calculate it anyway. Okay. Okay, we can skip this and we'll move. Why I'm asking this, because there is a large database came from pediatric difficult intubation, including 13 children's hospitals in the United States between August 2012 to 2015 and January 2015, including more than 1,000 pediatric tracheal intubation. You can see here,
No,
can you remove it, please?
it is the first word still.
Okay. You can see here, we have only about 20%, 1/5 of respondents are using indirect laryngoscopy, video laryngoscopes as a first choice for tracheal intubations in pediatric, which is interesting indeed. If we take a look for applications, that could be a first choice for elective oral, as well as nasal intubation in pediatrics and also neonates. Here is an interesting case report for nasal intubation in a pediatric patient with large. Okay, we have a poll here. Can we respond to it? Have you ever used the video laryngoscope in a pediatric patient? Regularly, occasionally, rarely, never, not accessible. Can you choose one of these answers, please?
There's 128
Yes, for
answers.
the result. Yeah, please, can we take a look for results?
16 regularly. I will show you now.
Okay.
Okay, now you see that?
No.
Okay, that is very interesting. You can see we have about for more than 40% are not using video laryngoscope, or they don't have video laryngoscopes accessible for pediatric patients. I think that's much more than this United States study, including 18% of people are not using a video laryngoscope as a first choice. We can proceed. We are still talking about the application of video laryngoscopes and as a first choice for intubation for oral. And here in this case report was a large mass in the mouse, including the mouse for a nasal intubation. Additionally, using of PUGI for a nasotracheal intubation for children less than 18 years, that is documented to be better than with the CMAC, which is the one of video laryngoscopes. I'll address it later on. It reduces the complications. You can see the using of PUGI with here, as you can see, the using of PUGI with the CMAC is associated with significantly less bleeding, nasal bleeding. And additionally, you can see patients' ages ranging from 8 years up to 66, including both pediatric and adult patients. Anticipated difficult laryngoscopy is another indication for using video laryngoscopes, or even for unanticipated difficult laryngoscopy. If we go back for the DAS, the Difficult Airway Society algorithm for difficult airway management in children aged 1 to 8 years, and you can take a look here for step A, For initial tracheal intubation plan, when the mask ventilation is satisfactory, you don't have a problem in ventilation. With more than 4 attempts using direct laryngoscopy, you have to consider using a bougie, straight plate, or video laryngoscope. So this is for unanticipated or anticipated airway difficulty. You know, in thoracic surgery, you need, for pediatric patients, you need to isolate or separate the surgical lung. So in small kids, less than 6 to 8 years or 6 years, usually we are using blockers. Blockers, particularly for infants and small kids, it will be difficult to be introduced through the lumen of endotracheal tube because of the small diameter of the tube and the smallest available diameter of 5 flexible bronchoscope, just 2.6 or 2.7 millimeter. So in this case, placement of bronchial blocker directly through the glottis to intubate the patient with blocker and then introduce the endotracheal tube alongside. Using video laryngoscopes can facilitate this. Here is a reported case of using of armed blocker with inserted outer to the tube using a CMAC from Sturs. As you can see here, the blocker is going directly through the glottis before inserting the tubes, and the tube is inserted alongside the blocker. Also, you know, for a flexible, for a bronchoscopic intubation in pediatrics, you need either to go through nasal airway or to introduce a laryngeal mask as introducer for your fibroscope or as a conduit for a flexible bronchoscope. Using any of the channeled or traditional blades, video laryngoscopes could be helpful in such case. Here is one of the traditional curved blade glide scope is used in 2 years old pediatric patients. And you can see here in the simulation mannequin inserting of the video laryngoscope and fiber optic bronchoscope could be inserted alongside the blade. The benefit here, you are investing the presence of video laryngoscope to taking the soft tissue and tongue away from your passage, and you have to go directly to the glottic opening, facilitate endotracheal intubation. Also, we described before using King Vision plates. That was one of the channel plates with a fiber optic bronchoscope for facilitating of intubation in adults and pediatrics. Awake tracheal intubation directly using video laryngoscope. Here is a case report using a CMAC in such patient with severe craniofacial malformation secondary to amniotic band syndrome. And in this case, they take awake lock with a video laryngoscope. Here it might be raise a concern why they didn't intubate directly as long as they can seize the glottis before induction of anesthesia. Awake intubation using the video laryngoscopes is well known, and here is reported in 10 years old boy with morbid obesity and multiple comorbidities with body mass index 37, and awake intubation was accomplished here successfully. We have here one of our cases. In this case, it is not the tongue. On the left side here, it is a large mass. It's a newborn, 3 days old. And this is a large mass, including the mouth opening above the tongue. And you can see the mass is protruding from here. If we take a look here about for this video, you can see we did awake intubation. You can see the glidoscope is inserted beneath the mass and above the tongue. So the mass up here is the mass, it is not the tongue. And with glidoscopic guidance, we advanced the tube into the glottis with some navigation to facilitate passing of the tube. And here the patient is awake after intubation using a glidoscope. Training of novice practitioners could be facilitated with using of video laryngoscopes because we have a remote screen. So you are sharing information between the mentor and the trainees to facilitate training of people before going to live patients. Here is an example of efficacy of Airway scope from Pentax for training of pediatric airway. Then this study, including 100 patients and including 2 simulations, BBSIM, and here on the right is the ELS baby mannequin. Both of them airway scope compared with a straight blade of Miller blade, it could be successfully reduce the time of intubation in both mannequins. Interestingly, this is secondary to increasing of success rate with using Airway scope compared of Miller in this simulation-based study. Advantages of using video laryngoscope, eye and Airway need not line up, because as you know, if we take a look here for this X-rays, we have a tracheal axis, we have a pharyngeal axis, and we have oral axis. To use direct laryngoscope with Macintosh or Miller plates, you need to align all of this axis to take a look directly into glottis. However, with video laryngoscopes, like a channeled video laryngoscope here, we can see the two axes, pharyngeal and tracheal axis, are almost aligned together. So there is, and you are looking to a remote screen, not directly into glottis. So this is the advantage of using a video laryngoscope. Here we have what's called external angle between the Macintosh plate and the tracheal tube. Here is the angle is 20 degrees, but it is reduced to minus 20 with using of channel video laryngoscope on the right image here. The problem of alignment of the three axes, if you have a patient with limited mouth opening, like this patient with congenital malformations, pediatric patients with morbid obesity, cerebral palsy with neck deformity and fixed rotated head to right side, patient with arthrogryposis, or patient with mucopolysaccharidosis syndrome, or patient with microphallus occlusive syndrome, all of them video laryngoscopes successfully used in them. Also, it is helpful in case of limited accessibility. For example, if you are going to anesthetize the patient in the MRI suite or in CT suite and with using old machines, which is a longer one, and the head is not accessible for you. If you are going to anesthetizing a patient in prone position and there is the problem in your tube, using a video laryngoscopes could be helpful here. We described using of tracheal intubation in prone and lateral position in a patient with encephalocele using a glidoscope. Also, other benefits, others can see and help you. If you have a difficulty, you need some advices from others. They are sharing the image on the remote screen and can help. Also permit sharing of medical information among team for during one of intubation. You might found, like we found here, some papillomatosis, and you call ENT surgeon to take a decision and change the surgery for the patient. And same if you have a tracheal web discovered during intubation, during glidoscope, as you can see here. We have a disadvantage for video laryngoscopes. They are not angels anymore. There are variable learning curves, which may take longer to intubate. The problem to take a longer time to intubation, particularly in pediatrics, that you are going to expose the pediatric patients to risk of hypoxemia. By building up of learning curve and increasing the experience and the skills gained by practitioners, this time to intubation is expected to going down. If you take a look for this study, including 77 operators with various experience in pediatric tracheal intubation, performed 10 attempts of tracheal intubation using glidoscope, AirTrack, McGrath. All of them are video laryngoscopes. You can see the time to intubation is significantly decreased, starting from the third attempt here, and also from fifth attempt. So the time of intubation is decreased from the first trial up to the 10 trials. The 10 trials, that's meaning you have a 10-time experience. That's the beginning one. Ease of intubation also is decreased from the third attempt, as you can see here on the left side. The passage of tube may difficult despite grid view. You have to put in your mind a good visualization of the glottis doesn't translate anymore to ease of intubation. You can get a perfect view with a video laryngoscope for the glottis. However, your tube, because of its natural curve, it's going to the esophagus. That's why you are usually advise your colleagues to get the tip of laryngoscope away from the glottis. You need to sacrifice with this optimum view to just a good view to allow the natural curve of the tube to going anteriorly to the glottic opening. As you can see here, we have a good view. We are sacrificing with excellent view for the glottis. We keep the tip of glidoscope away from the glottis, because otherwise you have the tubes going directly to esophagus rather than to glottis. Fogging and secretions may obscure view. There is a simple trick. Just turn on your video laryngoscopes for 45 seconds or 60 seconds in advance of intubation. That leading to heating up of the bulb or light source of the camera and avoid leading to vaporization of fogging and secretions from it. And do suctioning before inserting your video laryngoscope. Some video laryngoscopes, as I'll describe, are associated with inherent anti-fog mechanism. Loss of depth perception. You might know our colleagues in surgery, they are training them to be skilled in moving of hands using clamps and cutting, doing cauterization and so on in a distant place on the remote screen. There's the same problem here. We have a loss of depth perception, needing to more be skilled in using video laryngoscopes. What is the problem? If you are focused on the screen and you are going to introduce the tube without looking into the mouth of the patient, that is leading to software palate injury, soft tissue injury, anteroocular perforation. This is why we have usually 4 golden steps in using any video laryngoscope, particularly for the curved blade laryngoscopes. You have to first look into mouth while introducing the tip of the scope, then look to the screen for the glottic image, and then introduce the tube while looking into the mouth to avoid injury of lingual nerve or palars or soft tissue by the tip of the tube. And last step is look to the screen to direct your tube to the glottic opening. Here are just an example, some examples of palars infiltration. You can see here is the hypopharynx. Here is the anterior palar, it's perforated by tube. Secondary to using of different laryngoscopes, video laryngoscopes, glidoscope, air track. And also in our theater, we have one reported case, as you can see here. We use the titanium glidoscope blade, and there is a perforation of the anterior pillar during insertion of armored reinforced tube, required repair and the changing in patient's voice after surgery. So it is a hard lesson to be learned. We are talking about a more complicated technology and very expensive technology indeed. We have many products, many suites available in market, and much confusion. I can summarize the type of video laryngoscopes into 3 main categories. Stylets, which like any stylet you are using, but this is a video stylet. And we have a guide channel, this video laryngoscope with a channel alongside its blade to introduce the tube through it. Or traditional modifications for our commonly used Macintosh blade, which is a curved blade. Usually, we are reserving stylets and guide channels for patients with limited mouth opening or limited cervical movement. The next poll, Dr. Saad, please. Dr. Saad? Okay, the question, if you have access to video laryngoscope, which of the following types of video laryngoscopes are used in your practice, particularly in pediatrics? Stylet rigid video laryngoscope, a video laryngoscope with a guided channel, a video laryngoscope with an angulated curved blade. Please click on your answer.
Still signing.
Okay.
Okay, end now. Okay, it's here now.
This is very interesting. You can see about half of respondents are using video laryngoscope with angulated blades, and 1/4 or more than 1/4 are using guided channels. About 20%, 22% are using stylet rigid laryngoscope. This is very interesting indeed. And here I'll go to the next slide. We'll start with the statelets. We have two types available in market up to the best of my knowledge, bomb fields and multi-view system. Bomb fields coming from stores, and they have portable light source, or you can use any light source from Pentax, or even stores and stores, or even Pentax at your theater. There is eyepiece here. There is a piece to providing option. You can see it is a rigid plate, and we have also an angulated tip here. There is an eye tip. Usually it's connected to camera system. It is available in an angle of 40 degree. Here is the 40-degree angle. And there is two sizes available. Size 2 can be used with tube 2.5 to 3.5 for first year kids. And above first year, you can use 3.5, which can be used with endotracheal tube size 4 to 5.5. There is a case report about using bomb fields for endotracheal intubation in a patient who is 8 years old with temporomandibular joint ankylosis. Also, this is another mannequin study. You can see here a mannequin study in two scenarios, with easy scenario and difficult airway scenario, with increasing the Cormackley hand to grade 3B. You can see bomb fields as comparable time to intubation with direct laryngoscopy during normal and simulated difficult airway. However, success rate is 100% with bomb fields. This is a study including 150 intubation by 10 anesthesiologists using a tube size 3.5. You have to put in your mind the size of tube is one of the most important independent factor which can determine the success rate for intubation. The smaller the size of the tube, the higher the success rate. Another study including 60 trainees with 5 trials with endotracheal tube size 3, comparing bomb fields and regular rigid bronchoscope in 3 scenarios: normal airway, anterior larynx, or Pierre-Robin syndrome. The time of intubation is significantly decreased from the first trial to the 5th trial. And there is no big, and there also time of intubation is longer with bomb fields compared with the rigid bronchoscope. This is a normal and anterior larynx simulation. And same differences are reserved in Pierre-Robin simulation as well. This is a video demonstration for using all statelets laryngoscopes. This is an example of using of bomb fields. You can see the cameras connected to the tips there. And, and light sources connected here. Here is the shaft. In all video laryngoscopes, you need to lubricate the blade or shaft of your video laryngoscope and endotracheal tube. Here is the endotracheal tube is going to be loaded over the tip of video laryngoscope after turning off light source. One of the golden tip here is the holder for the tube to fix it. And you can see this part, you can apply oxygen to the patient. One of the most important points, you have to avoid that the tip of statelet is going outside the tube. Otherwise, you are going to injure the patient's soft tissue. It shouldn't be like this. It should be retracted inside the tube, as you can see here. And then you have to use a traditional direct laryngoscope just to remove the tongue away from your passway and introduce the bomb fields with the tube overrolled over it. Alongside the right side of the plate, behind the molar teeth, is called bomb fields retromolar endoscope. And you started with angulated to the left side until you found the glottis, then rotate yourself to make the angle angulated forward. And then introduce the tube inside and get your statelet outside. The next one of the stelets is multi-view. The difference here between bomb fields and multi-view is the tip here is deflectable. That's meaning you have a handle in your hand and you can change the angle here. It's flexible up to 20-degree angle. Here is a 20-degree. You can move the tip up and down like a mobile stylet, like Schroeder stylet, if you know about it. The viewing angle is variable between 60-degree plus or minus 50%. There is a portable screen on the handle, it's 2.2-inch LCD screen with 2.5 megapixels. You can apply also a continuous auction from this port. And we also is available in 2 diameters, 2.5 to can use the tube 3 to 3.5 for first year kids, and outer diameter of 3.5 it could be used for endotracheal tube 4 to 5.5. Also here is described using of multi-view scope for 21 months old patient with Schwartz-Jampel syndrome with a congenital malformation of the face. This is an interesting study including 15 expert, 15 resident with endotracheal tube 3.5 in 2 scenarios of normal airway and European stimulation, as you can see here, using a multi-view. The time to intubation is significantly less with multi-view than comparable and is comparable with different with direct laryngoscopy in both normal and difficult airway simulations. AirTrack, we are talking now about channeled video laryngoscopes. We have 2 types of AirTracks available in market, the gray one, size 0, and pink one, size 1. Size 0 for tube 2.5 to 3.5 with a mouse opening up to 12.5 millimeter. Size 1 can be used for tube 4 to 5.5 for the mouse opening, a minimum mouse opening of 12.5. It is a channeled video laryngoscope with 90-degree shape. There is a built-in anti-fog system. Just you need to turn it on the light source for 30 to 45 seconds. It's low cost, about $90, and single use, of course. You can use any smartphone, either using iOS or Android, with a specific holder to use it as a viewer, and you can transmit images by Bluetooth. Also, there is a Bluetooth piece here. You can take image and you can save and you can record. Also, you can use any stores or Pentax or other video camera for displaying. Here, this is an interesting study including 83 novice nurses with a mannequin 6-year-old BDSM and chest compression system locus, and using endotracheal tube of 5. You can see the time of intubation with BCR in difficult and normal airway, and even without CPR is significantly less with AirTrack compared with Macintosh. Pentax airway scope is coming from Pentax. They are available in 2 sizes. The pink one is the pediatric one, can accommodate tube 5.5 to 7.5. Infantile one is including neonate for neonates, tube less than 5 millimeter. Both of them are uncuffed tubes. The view angle is 80 degrees. This is the largest angle visualization angle available in market for channeled video laryngoscope. There is a channel LCD screen, 2.5 inch with very high resolution and channel plate. Interestingly, there is a crosshair display, like you are going to shoot the tube into the glottis, which facilitates the intubation indeed. Here is a description of using a Pentax airway scope after feeling intubation with McGrath in a 12-year-old girl with golden hair syndrome. Also in this study, including experienced anesthesiologists, more than 10-year experience with more than 50 intubations, and the tube was calculated per age, they found using a Pentax airway scope has a comparable time to intubation with Macintosh, so there is no difference here. However, interestingly, Pentax associated with more teeth injury than Macintosh, than direct laryngoscope. King Vision is another channeled video laryngoscope, is available for pediatrics with also viewing angle 80 degree like Pentax. Also, we have a display screen of 2.5 inch LCD. They have both non-channeled standard and channeled blades with anti-fog treatment mechanism. You can see we have size A, non-channeled, size 2 channeled and non-channeled for pediatrics. Usually size 1 is used for pediatrics less than 1 year, size 2 standard, and size 2 channeled used for children 1 to 10 years. Size 3 can be used for more than 10 years. And there is a difference of mouth opening. Mouth opening, it should be as a list of 10 millimeter for size 1. And for standard blade to 10 millimeter, 13 millimeter for 2C. Interestingly, in this study, including 200 patients less than 2 years old by 5 experienced anesthesiologists using King Vision or Macintosh, time to device out is significantly less with King Vision. However, there is no difference between time to intubation using direct laryngoscopy or King Vision, with the trend towards higher time to intubation, but not statistically significant with King Vision. Vivitrac. Vivitrac is interestingly stainless, single use, available in pediatric for endotracheal tube size 4 to size 6, and has a stainless plate anti-fog treatment. Excuse me. As you can see, there is a USB connecting cable. It could be connected to any tablet, to any laptop, computer, or screen, including operating by Windows 7 to 10 or Android 4.42 or greater with integrated USB cable. The next channeled video laryngoscope is FlexView. FlexView, as you can see, we have a grip. This grip leading to articulating tip to be moving forward. It is a channeled video laryngoscopes, and it's described to be used in pediatrics. Here in this video demonstration, I'll show you how to use any type of video laryngoscopes as an example of the AirTrack. You have first to lubricate the tube and lubricate the tip of a video laryngoscope. Insert the tube through the channel. Turn the light source on. Do suctioning for the glottis to avoid obscuring of your view with secretions. And now insert the scope with the mouse and through the mouse with the display facing the feet of the patient, as you can see. Then advance it in with moving it backward towards you with some twisting movement to adjust the view, and then advance the tube through the glottis, hold the tube in place, remove it from the channel, and get your scope outside. Don't forget to inflate the cuff of the endotracheal tube. Traditional modifications from its name, it looks like our routinely used the Macintosh plate, the curved plate. All of them are coming from the same concept. Coptic VLB100, it resembles the direct laryngoscope, as you can see here. There is attached screen 3.5-inch red, green, blue over the handle. The angle is too small indeed. This is 39. Small angle compared with other curved plates. Is available in size 2 and 3 Macintosh curved plate and straight Miller plates 0 and 1 for pediatrics. Stur's CMAC is 60 degree, and it is available in also Macintosh curved plate 2 and 3 and straight Miller 0 and 1. There is a very high resolution camera with 15 megapixels. Is available in straight and curved blade, as I told you. The angle is 60 degree. Here is the angle. Also, Stur's introduced a single-use blade with a fiber optic reusable cable and disposable plate, both curved and straight. It's a single-use CMAC S. Here is the angle, 60 degree as well. Also, there is the portable pocket monitor, which is a 2.5-inch portable screen. And recently, they introduced a versatile CMAC with a portable aside remote screen. It's connected by a cable 50 millimeter in length, and the screen is 3.5 inch. The idea of remote screens, as you can see, it is propagating after the era of COVID-19. Because if you are using video laryngoscope, you have to choose a remote screen rather than the one attached to the handle to stay away from the mouth of the patient in case of infection in suspected or positive patients. CMAC with D blade, the pediatric D blade, is the largest angle for a curved blade available in market. From its name, D, letter D, you can see the angle is 80 degrees, and this is the letter D, because if you draw a line here, you have a D shape. Here is the D shape. In this comparative study in children aged below or greater than 1 year using a CMAC or Macintosh, any reported complications, there are non-significantly higher rate of complication with CMAC, and however, and there is no difference in first pass success rate in this study. This study including 452 intubations on 422 patients less than 18 years old. McGrath. McGrath is available with a remote screen over the handle. It's 2.5 inch. Is available in reusable and disposable plates, size Mac plates, curved plates, 1, 2, and 3. Also recently they introduced the McGrath MX blade, with like a D blade of CMAC with 80 degrees. There is a study including 75 novice paramedics using McGrath with inline stabilization in the mannequin or with the C collar. You can see the first pass success is 99 with McGrath compared with Macintosh and inline stabilization, and still high with 93% compared with 45 with C collar. Glidoscope was first introduced in Canada and including a plastic plate curved to 60 degrees. Here is the angle, and had the reflective screen with a high quality screen. We have described the 4-step technique, and I'll show it for you later on. There is a plastic curved to 60 degrees. It is available in titanium, low pro to 2, or a disposable plate. Glidoscope AVL, they available for pediatrics in size 0, 1, 2, and 2.5. For McGrath with Glidoscope Go, 3.5 inch landscape, which is available also in size Lupro S1 to 2.5, 0 and 1 as well. For curved plates, 3 sizes, 1 to 2.5, and the straight plate 0 and 1. Co-pilot, it has a blade with a port allowing introducing a bougie. There is a remote screen, and it is a 4.3 detachable screen. The cheese are disposable, is available in size 3 and 4, and provided with a rigid stylet. Into Bright, it is another traditional modification. It is a stainless steel with a Mac plates 1, 2, and 3. Miller plates, you can see here in this one, this curved plate 1, 2, and 3. Miller is available in 00, 0, 1, 2, and 3. And also Phillips blades 1 and 2. TrueView, and TrueView is BCD is another technology. It is based on the rarefaction. You know, the rarefaction in ocular physiology. It is the same concept. There is optical lens here, and the image coming is you just a rarefaction with a 40-60 degree, and it is available in 5-inch LCD and the stainless steel blades. It is available in size 0 for kids less than 1 year, size 1 to 1 to 3, 2 for 2 to 16 years, and size 3 more than 16 years. There is a study including 153 patients less than 16 years old with normal airway. You can see the success rate is 90%. This is observational study, and you can see success rate. It could be translated into optimizing the glottic view. You know, the grade 1 in Cormackley hands, that's meaning the best view. 93 of patients are associated with such good view. UE scope. UE scope is available as a touch screen 3-inch, is a single-use plate, is available in size 0, 1, 2, and 3. In this interesting study, compare using Manicam 5 years old with a cordless CPR system with chest compression and using UE scope for intubation, the first pass success was significantly higher in normal airway and difficult airway, normal airway with CPR and difficult airway with CPR compared with a Miller blade, a straight conventional blade. Also, time to intubation were significantly less in all scenarios of normal and difficult airway with and without CPR using UE scope. Here is a video demonstration for using any type, the standard of using of any type of traditional curved plates. You have to first use staylet with all of them. Don't forget this. You have to lubricate the staylet. This is the glidoscope. You have to insert that the glidoscope. The first step, as you can see, lock into the mouse to avoid injury while you are introducing the tip of plate through the mouth of the kid. Then the second step, you have to look to screen to find the best glottic view. You shouldn't introduce your tip too far in. Third step, look into the mouse again while introducing the tube, and fourth step, look to screen when the tube is going towards the glottis and the view area over the screen. And then introduce the tube, remove the staylet, hold the tube in, inflate the cuff, and remove the blade. Now, as you can see, we have many types, much confusion. So we have staylets, we have guide channels, and we have traditional modifications. So many products and much confusion. So which is best? This is a difficult question to be answered because there are few studies comparing them, and most of them are Manicam studies. Here in this study compared glidoscope here in about 100 patients with Bonfils retromolar laryngoscope. You can see the glottic view, Cormack-Lihan grade 1, which is the best view, is more with Bonfils than glidoscope, and also BOGO. Excuse me. It is the percentage of optimum glottic view. It should be 100%. If less than 100%, 0%, that's meaning all patients or this 44 patient have 100% best view using Bonfils. This is the 100 patients with normal airways. As the comparative study between AirTrack and glidoscope for a time including 26 pediatric intensive care clinicians with diverse experiences, and they used GVL glidoscope with AirTrack on Manicams. They found time to intubation with significantly less. You can see it is a big difference between 19.5 seconds to 46 seconds using glidoscope. That is thanking to not the AirTrack per se, but for anyone of channel video laryngoscope, the presence of channel facilitate just you are introducing the scope to the tip and then the tube going through the channel directly to the glottis. So this is thanks to the channel of this guided laryngoscope. This study including 65 anesthesiologists and 15 practitioners, and also pediatric critical care medicine. They are experienced with using of each device. They're comparing King Vision, D-blade of CMAC from Shores, and conventional curved Macintosh and straight Miller. They are using two simulations, normal airway and difficult airway with limitation of neck movement with something like a neck collar. You can see there is a big difference here in time, statistically difference here, but I think it is unreliable study to found a difference of 1.5 seconds between King Vision and CMAC with a p-value of 0.01. So I would overlook this study. In another study, including 45 novice anesthesiologists and anesthesia nurses, using a 3 to 6 months AirSim Manicam with Pierre Pain anatomy, they found time to intubation was significantly less using Miller plate, of course. But you can see in McGrath, there is no difference between CMAC with a Miller straight plate and McGrath. It's an interesting study, including 107 novice paramedics using endotracheal tube size 5 and 6-year-old mannequin with chest compression using locus system. They compared COPDEC, co-pilot, Entoprite, and the traditional Macintosh plate. They found time to ventilation are comparable. There is no difference between the 4 groups. However, if you take a look for time to intubation, was significantly less with co-pilot and COPDEC and co-pilot. So COPDEC and co-pilot are performing better than Entoprite for endotracheal intubation and child during chest compression. So in conclusion, unfortunately, no one model appears uniformly superior to another. What you have to do, you have to use what is at your hand. However, if you have the opportunity to purchase or to get 2 types of video laryngoscopes, if you have such luxury, you have to choose to get 1 apple and 1 orange. 1 apple, it could be stained video laryngoscope or channeled video laryngoscope, which would be helpful in a patient with limited mouth opening and limited cervical movement, and angulated video laryngoscope for better visualization, particularly if you have a bleeding from airway, if you have vomits, if you have extreme difficulties, and so on. And finally, thank you very much for listening, and I hope you enjoyed this evening. Thanks so much.
Thank you, Dr. Tahan, for this interesting, informative, and updated lecture. Please, Dr. Saad, allow my camera.
Sure.
Now the floor is open for any questions for Dr. Tahan. We have one question, Dr. Tahan. I think you addressed, but the audience need more information. Dr. Isam asked about what do you prefer, or is AirTrack is superior laryngoscope?
Can you start your camera, please?
I cannot conclude for this fact. There is a meta-analysis comparing channeled video laryngoscopes, but in adults, not in pediatrics. They found AirTrack is better than others. However, for pediatrics and up to the current available information from literature, we cannot reach for this conclusion. Using of any channeled video laryngoscope, it could be helpful in a patient with a limited mouth opening and restricted neck movement. However, you have to put in your mind, you should be very skilled in what you are using, regardless of the type.
Okay. Also, Dr. Hisham Saleh asked about, he found difficulty during passing the tube, although the view is very obvious and clear.
That is,
ask you how to overcome this problem.
Yes, that's what I explained during the talk. This is one of the major problems. You can insert the tip of the scope until the glottis to reach for the best glottic view. But in such case, you cannot advance your tube in natural care. You need to sacrifice with this. You have to get the tip of your laryngoscope, either channeled or traditional plate, as far away from the glottis, just to see part of the glottis in a good view, but not an optimum view. Then insert your tube, the natural curve, with a hockey stick stylet, reshaped stylet. It will advance the tube into the glottis. Of course, in channeled video laryngoscopes, we are very rare to use stylets. We don't need to use stylets, but you might need to use bougie in such case. Also, this might facilitate introducing the tube. You need to intubate with bougie, with the reshaped tip of the bougie to 30 degree or hockey stick appearance, to intubate with bougie, and then advance through the channel, the guided channel of the scope.
Thank you, Dr. Tahan. Thank you for this updated scientific talk. Thank you.
Sorry, I have a question, Dr. Tahan, about do you have experience with Barker tube, with flex tip siliconized tube?
Yes.
Just prevent this issue?
Yes, to some extent. Yes, there is a problem in this one. You need to rotate the tube 180-degree counterclockwise to avoid hitting against the cord to introduce it.
Thank you.
Welcome.
Okay. Thank
Dr.
you.
Tahan, I have a question, if you don't mind, from myself.
Sure.
Do you think that video laryngoscopy are going to be, especially in this time of COVID, are going to be a little bit more widespread, as we would like to improve the experience of the beginner or the trainees to use the, the normal conventional laryngoscope, and they now are moving swiftly to video laryngoscopy to avoid direct contact with or potential contact with the COVID air droplet infection?
Dr. Saad, this is a very important question indeed, and I thank you for highlighting this. All guidelines released from BSA, from ASA, from ASA, from CRT, and also from EACTA itself. It is a recommendation, and Difficult Airway Society, of course, European Difficult Airway Society, all of them including the first and only choice to use a video laryngoscope as much as possible and accessible. Yes, it is a problem. I know it has a financial constraints. However, there are many introduced cheap video laryngoscopes coming. It is not a brand, but it is working well. It's coming from different areas, from China and India, and I think they are working well at an affordable price to some extent. Yes, I agree with you. It is a problem in training, and not only during COVID era, but also before COVID era, because during this time we are afraid about our patients indeed. Okay, and we don't have such luxury to have simulation in advance. Yes, we are offering for them a half day or 1 day difficult airway workshops, but it is not enough. So we are using video laryngoscopes to avoid injury for our patients, particularly when we are talking about pediatric patients. They might affect their skills in using traditional blades and straight blades to gain the skills with straight blades, with curved blades, which sometimes the video laryngoscopes is not a common, and it is only my own experience. And very few number of cases you might gain experience and you get difficulty in using a video laryngoscope, and you have to go back for a straight blade sometimes. And here is the problem. But if we discuss this problem from other aspect, if we look for specialization in surgery, like special types of specialization in surgery itself, for specific type of surgery, for laparoscopy, for endoscopy, and so on. These surgeons also, they are lacking experts and experience and skills, and using general surgery for laboratory, for exploration, and so on. It is the same problem. It is obvious it would happen with anesthesiologists in next generation.
Thank you.
Welcome.
Any other question from the floor, please? Very nice. And at the end, I would like to thank all eminent speakers tonight. The first time to use modular teaching today, pediatric anesthesia and neonatal anesthesia. I would like to thank always. The first one is Professor Samir Ansari. He's honored us by his presence today as a moderator of this session with Professor Manal El-Gohari. The three top speaker experienced anesthesia, pediatric anesthesia in the world, Professor Hani Zahabi, Professor Mu'taz Abdurrahman, Professor Muhammad Tahan. I can't thank you enough on behalf of my colleagues and on behalf of all attendees. Next Sunday, we are starting to just move the time a little bit forward at 7 o'clock Cairo time. Just to keep tuned, if we decide about that, we have to have voting with our professor and our colleagues, because the people in the Gulf area and the Far East are a bit late at the moment. We're in Dublin and England. We are okay. That's fine. We can stay longer, but they are, I think, they are around 11 before midnight there. Next Sunday, we will have Professor Samir Ansari again with a very nice, interesting case discussion in cardiac ICU. And Professor Magid Salah will have speak about advanced cardiac monitoring and cardiac anesthesia. And once again, we have our top speaker tonight, Professor Muhammad Tahan again, and he will speak to us about very, very interesting topic. We'll keep it in the advance in the advertisement. And everybody, thank you very much, and good night, and hopefully we'll see you again. That is one of the most successful sessions in the MEGA online course. And on behalf of my colleagues, I would like to thank you very much, and hopefully we'll see you again.
سعد بس تحط الفيديو عندي سلام للناس إذا ممكن يعني if you don't mind. الفيديو عندي is the video is
oh sorry دكتور معتز دكتور معتز sorry دكتور معتز I haven't seen that. Your lecture was very interesting, interactive discussion. You know, I'm so proud of you tonight. I'm so proud of myself that I am here between all of those eminent top people in the Department of Anesthesia. And thank you again. And hopefully we'll see you again next Sunday. Thank you.
Thank you very much all. Thank you.
Thank you.
Thank you.
Thank you, Brockman. Thank you.
Dr. Muhammad, Dr. Hani, everybody. Thank you very much.
Thank you.